Okay, we'll make a start now. Thank you ever so much for joining us this morning for the latest in our mental wellness series that we've been running from the Department of Experimental Psychology here at the University of Oxford. And you might be joining us live or on YouTube, but welcome to you. And before we start, I just wanted to do a little bit of a reminder about the series for those of you who've joined before and those of you who may be new today. So we've been running a number of sessions from experts in the departments of experimental psychology here in Oxford and also from our colleagues across the university. And there have now been a number of sessions which are all available on our Department of Experimental Psychology YouTube channel on topics including depression and low mood, bullying, mistrust and paranoia, trauma, eating disorders, sleep problems, stress and anxiety. And the next session after today will be on the 18th of November by Dr. Kirsten Smith, which will be focused on coping with grief after bereavement. So please do join us for that as well. But today we're going to be talking about social anxiety, and we'll be running until 10:45. So please do take a moment after the session to take a bit of time for yourself. We'll also be sharing some links which we hope will be useful for anyone who may want to seek further support after the session. But without further ado, I'm really delighted to welcome Professor David Clark, who is Professor and Chair of Experimental Psychology here in Oxford and a Fellow of Magdalen College. And he's also co-lead of OxCADAT, which is the Oxford Centre for Anxiety Disorders and Trauma. And David is an international expert in the treatment of a number of psychological disorders, including social anxiety. So we're extremely delighted that he's been able to join us here today. Thanks very much, David.
Thank you, Cathy, and welcome everyone. What is social anxiety disorder? So it is really common for many of us to feel tense or anxious when initially meeting strangers, and particularly in situations where we might feel there's some social evaluation, such as public speaking or performing in public. However, for some people, that fear becomes much more widespread and extends to much more casual conversations where there isn't any obvious evaluation, or it can become much more persistent. And in those cases, we diagnose what we call social anxiety disorder, which is a persistent fear of one or more social situations. Mine now is a classic one, public speaking, and about a third of the population has a fear of that. But for most people with social anxiety disorder, they also are concerned about many other situations, casual ones such as having a cup of coffee with someone, meeting people at work, almost doing anything where you could be observed. And the key feature is that people fear that when they're anxious, they will act in a way which will be humiliating or embarrassing. So they think they will do something which will lead to their humiliation or embarrassment. And the most common thought actually is the idea that people will see you're anxious and then think badly of you because of that. So to some extent, it's a sort of fear of fear or fear of other people seeing your fear. But there are other thoughts as well, as we'll see in a moment. The situations that people fear do vary quite a bit from person to person, but in general, they will try and avoid them if they can. But modern life is such that we have to meet people more or less every day. And so people with social anxiety often endure social interactions with considerable distress. And we'd only sort of diagnose the problem if we think the fear is out of proportion to the objective sort of evaluation in the situation. What are the sort of thoughts that people have when they're anxious? These are the sort of classic ones. People concerned that what I say sounds stupid, I'm boring, I'll make a fool of myself, the other people won't like me. The classic one, they'll see I'm anxious. And then if people do see you're anxious, what are they going to notice? I'll blush, I'll shake, I'll sweat, I'll lose control, I won't have anything to say, are very common thoughts. So what do we know firstly about the causes of social anxiety? Well, really, it's a multifactorial cause. There is genetic vulnerability. Some people are more vulnerable than others to the condition, but the genetic vulnerability isn't specific to social anxiety. It's a vulnerability that increases your risk of depression and many other anxiety disorders as well. So we also have to look at things that interact with those genes, and particularly early adverse experiences seem to be important, such as bullying, abuse, public embarrassment, often in childhood, seem to then, for some people who are already perhaps somewhat shy, sort of stamp in a more severe form of social anxiety. And there is some evidence that parental modeling can also sort of increase social anxiety in people who are already vulnerable, particularly overprotectiveness, where a child is really not allowed to interact much on their own or do things on their own, so parents are always being overprotective. What are the sort of consequences of social anxiety? Well, the first thing to know is it's the most common of all the anxiety disorders. About 12% of people at some stage in their life might meet the diagnosis, and in any year it's between about 4 and 6%. Typically it starts in childhood. About half of people will have developed the problem by the age of 13. Most others will develop it by the end of teenage years, and it can be very persistent in the absence of treatment. So there is a nice follow-up study looking at people in the community over a 12-year period, untreated. And the good news is that about a third of people did recover in that period. But of course, the bad news is that about 2/3 did not. And that's a lower natural recovery rate than any other anxiety disorder or depression. Often people become depressed because life isn't progressing the way they would like because of their social anxiety. Some people develop alcohol and drug problems really as an attempt initially to self-medicate for social anxiety. And it leads to marked underachievement in life. And that starts early in school, where children with social anxiety often feel self-conscious in the classroom, have difficulty in concentrating on what the teacher says, and so tend to do rather less well in exams than you'd expect given their IQ. Then when people are in the workplace, they're often less likely to get promoted than you might expect, because promotion isn't simply about how well you do the job, it's also in many contexts about your social interactions as well. So what can we do to treat the problem? Well, you'll have probably worked out that many of the causes that I've mentioned are all in the past. They aren't things that we can easily change. We can't change your genes. We can't change your early history of bullying or abuse. So the treatments really focus on what it is that keeps social anxiety going once it's developed. Adrian Wells and I looked closely at this in the mid-90s. We were interested in the puzzle of why it is that social anxiety persists, even though people keep on meeting other people and going into difficult social situations, because that's what we call exposure therapy, and normally that's quite effective treatment, repeatedly exposing yourself to the situation you're afraid of. But somehow that doesn't really work with social anxiety. So what is it that's preventing people from discovering that their fears are excessive? And if you take a cognitive approach, which is ours, what you need to do is get into the person's head, understand what they're thinking, and you saw examples of that just now, but also how their thinking changes their attention and their behavior. And we noticed two aspects of that. Firstly, people with social anxiety often report that while they're talking to other people, their mind is often on themselves. They're often, while they're listening to the other person, they're also focusing on themselves and thinking how they're coming across to the other person. They often say they feel very self-conscious. That sort of internal focus of attention is probably one reason why simple exposure doesn't help much, because if your conversation goes well, you may not notice it because you're lost in your head observing yourself. But it's worse than that, because when people focus on themselves, they become aware of what we would call internal information, information in themselves, which they take as very good evidence for their negative fears. One of them, of course, is anxious feelings. People are worried that they look anxious and they feel anxious inside, and they think that because they feel anxious inside, everyone else will be able to see it. That turns out to be a mistake. The more anxious we feel, the more we overestimate how anxious we look. So it's not as though you can't see that someone with social anxiety is looking rather tense, but if you ask them to tell you how anxious they think they look, it will be much more negative than you see in front of you. So their feelings are misleading them. You won't be surprised to hear that because people want to know how they come across to other people, they often also experience mental images in which they see themselves as if from an observer's perspective. So there's a camera looking at them. And unfortunately, what they see is not the way they actually look, but rather their fears visualized. So for example, one of my patients was a young teacher, and she would get very anxious when talking to other teachers in the staff room, concerned that they might think she was stupid. And she would get a feeling of tension around her lips when she was about to speak. And that feeling of tension around her lips would then trigger a mental image in which she would see herself looking like this. And when I asked her, well, what does that look like to you? She said, the village idiot. So she didn't need to check out from other people's responses how she was coming across. As far as she was concerned, she knew she looked idiotic because she could see it in her mind's eye. So these are two key processes: feeling self-conscious, self-focused attention, and then paying attention to misleading information, anxious feelings, and excessively negative self-perceptions. The additional factor that seems to be important is what we call safety behaviors. A safety behavior is something you do to try and prevent a feared outcome from occurring. So this teacher is concerned that she will come across badly to other teachers. They'll think she's stupid. So what does she do to try and prevent that? Well, the first thing she does is she gets up early and she reads lots of news feeds on her iPad and writes down a list of clever topics which she scrutinizes before she goes into the staff room, so that she can appear to be completely on the ball with current affairs, and hope that that'll get her through appearing not to be stupid. In addition, when she's talking to you, what she'll do is she will memorize everything she's already said and compare it with what she's about to say in order to check it makes sense. In order, and if she thinks it doesn't make sense, if she thinks it's not clever enough, and she often decides that, she will censor what she's going to say. She won't say it. Well, what's the consequence of these safety behaviors? The first, of course, is that if the morning coffee break goes all right, her fears won't change, because she'll think, I only got away with it because I did my safety behaviors. If I hadn't done that, people would have decided I'm really stupid. So the fear persists. But it's actually worse than that, because she would really like to get to know you. She would really want to be friends with you. But her safety behavior is inadvertently giving an opposite message. When you're talking to her, she will appear as though she's not interested in you. She will appear as though her mind is somewhere else. And it is. It's on her self-monitoring and self-preoccupation. And of course, people tend to then respect the fact that she doesn't appear to be interested in talking and tend not to talk back to her. But this then reinforces her idea that people don't like her. So these are really quite problematic processes. There's a lot of experiments that have looked at whether or not these processes occur in social anxiety, and it turns out they do. So there's very strong support for the model. But I'd really like to focus not on that, although you're very welcome to read those studies. Instead, I'd like to focus on the implications of this sort of model for treatment. So a particular form of psychological treatment, a particular form of cognitive therapy has been developed based on this model, and it has several key steps to it. The first is to discuss with patients what happens when they're anxious in a social situation, and develop their own personal version of the model, including their thoughts, their images, those safety behaviors, and how they interrelate. The next step is what we call an experiential exercise, where we do something to help people realize that self-focused attention and safety behaviors, although they're something they've been doing to manage the problem, actually make the problem worse rather than better. And we do that not by giving a lecture, but by experience. So we get people to have often a conversation with a stranger while focusing their attention on themselves and doing that sort of self-monitoring or writing down the topics and the safety behaviors, or doing the opposite, trying to focus more externally, dropping the safety behaviors. And what we find very consistently, and they find very consistently, but it's a surprise, is that when they focus attention on themselves and do their safety behaviors, they feel worse, not better. They feel more anxious, not less anxious. This is helpful because it motivates people to try and change those behaviors. We also look at these very negative images that people have of themselves. And we find, again, the best way of correcting that is not just to give reassurance and say, you come across much better than you think, but allow people to discover that themselves. And we find video feedback, if set up very carefully, is a very helpful technique to do that. We then move on to training people to focus attention more externally. And the crucial bit of therapy is then to test out your beliefs about how you come across to other people by dropping your safety behaviors and seeing what happens, and often finding you're accepted without hiding away. But also later in therapy, we sometimes ask people to actually do some of the things that they're afraid of, and then see whether they have the sort of catastrophic consequences they think they are. So if someone's worried about sweating, say on their forehead, we might ask them actually to put some water on their forehead and then go through a shopping center or buy some things in a shop and see whether people react as negatively to that as they think they will, and in general people don't. We also do a little work on helping people deal with some of the traumatic memories they may have if there were specific early traumas. So does that therapy work? Well, there are randomized controlled trials now in 5 different countries, and it has, in the trials, been superior to everything it's been compared to: exposure therapy, group cognitive behavior therapy, interpersonal therapy, psychodynamic therapy, treatment with medication. And the effects are pretty large. This study, this is our latest data of a trial, around about 100 patients with social anxiety. And you can see here the severity of the problem at the start of treatment. The clinical, non-clinical cutoff is about here at 30. So everyone's in the clinical range. They vary in severity. What I'd now like to show you is what happens to that distribution when people have had a course of cognitive therapy and we follow them up for a year afterwards. And you can see there's been an enormous shift in their social anxiety. Most people are now in the non-clinical range. For others, there's still worthwhile improvements, but we don't have any psychological treatments that work for everyone. For some people, one treatment doesn't work and they'll try another one. And here we have 3 people who clearly we weren't able to help. So there is scope for much more research still on this important problem. So that really covers the sort of quick summary of what we know about what keeps social anxiety going and how that can be used in treatment to help people overcome their problem. I thought I'd really end the talk by showing you a brief video clip of just one of the elements of treatment. So I mentioned that we will often get people to identify the safety behaviors they're normally using in social interactions to try and prevent the thing they're afraid of from happening, and encourage them to drop those safety behaviors and discover what happens, and fundamentally to discover that if they don't hide away, if they're themselves, they are going to be accepted by other people. And so here's a short video clip that illustrates this. Because this is a public presentation, you'll understand this isn't a patient that you're seeing, it's a reenactment of some work that was done with a patient.
A very common safety behaviour amongst people with social anxiety is to censor what they say in conversations.
I always used to keep quiet when I was in a group situation. It wasn't that I didn't want to join in. It's just that I was convinced that if I opened my mouth, it would all come out wrong and people would think I was stupid. And that did, yeah, that would really upset me.
My brother went to Spain actually.
In group conversations, Hannah tended to hold back and say little. Things popped into her mind to say, but she heavily censored what she was prepared to say.
The heatwave that we've been going through is such a rarity.
It was like that time when everyone was talking about the holidays in Spain. And I remember thinking about a tapas restaurant that's near our house and how I'd love to try the real thing one of these days, but I was just too embarrassed to join in.
Really hot and pleasant.
Yeah.
Nice.
And the food, isn't the food lovely?
I love tapas.
Have you ever been to Spain, Hannah?
No. I've heard Portugal's really nice as well.
Hannah had thought of what she'd like to say, but she held back because she feared it might sound stupid.
I think in my deepest, darkest thoughts, I did sometimes worry that if I said something stupid, then people would actually laugh or ridicule me. I'm not sure that they would actually do that, but it definitely felt like that might happen.
And I love tapas, but I often wonder, do you get the same thing in the restaurants here as in Spain and out there?
I always find it delicious here, but I wonder the same thing sometimes.
It always tastes fresh over there.
Hannah had made a conscious decision not to do her safety behaviour. She said what was in her head without censoring it. Only by doing this was she able to discover the other people responded positively to her. Building on this success, Hannah decided that she would try this out a bit more, not holding back and just saying what came into her head.
Have you ever been to the opera?
No, I've always wanted to go.
It made such a difference when I began to realise that I didn't need to hold back all the time. It definitely felt weird at first, but when I thought of something that I wanted to say, I would just say it and not think about it too much. I would just start to enjoy the conversation. Now I'm trying to practice this as often as I can, just in ordinary, everyday situations.
So that's just a snippet of the sort of things that happen in therapy. Normally, the therapy is delivered in sort of face-to-face sessions with the therapist once a week, and then people having homework to do during the week. But more recently, we've been developing an online version of the treatment, an internet-delivered treatment, where all the key procedures in the treatment are in the internet program, and you can access it 24 hours a day, 7 days a week. And then you have a short telephone call or video link with your therapist once a week, where they will look at the sort of things that you've learned from the program and strengthen that learning, perhaps do some exercises with you on the video. This is potentially much more convenient for patients because you don't have to travel to the clinic. You can do a lot of the work at the time that suits you. As it has all the key components of the therapy in it, including sort of video feedback, it really is delivering the same treatment, but just in a different way. And we're finding many people find this very appealing. And in our current research, it seems to do about as well as the face-to-face therapy. So we see this as the future. It's not a program that's fully available to the public at the moment. It's still going through research, but it does have some potential advantages for some people. The first thing is a potential advantage to the NHS. It reduces the amount of therapist time required to take someone through the treatment very substantially, up to 80%. It has greater convenience for patients, but we also think it's probably going to help really advance further psychotherapy research, because in an online program, you can really have very large samples of people going through treatment. And then that makes it much easier to look at that rather small proportion of people who don't benefit, because you'll have a larger sample of them, and then look closely at what it is that the treatment isn't doing to help those people, and then to refine the treatment. So we feel that will allow us to further refine treatments in the future. Also, of course, in sort of normal face-to-face therapy, therapists are human and they have on days and off days. The delivery of the content in the internet program, once you get it right, is of course much more consistent. So that has some potential advantages as well. Well, so that's really a quick whistle-stop tour through research on social anxiety and its treatment. And I'd like to stop screen sharing now and turn over to some questions.
Great. Thank you ever so much, David. I'm sure people will have found that extremely interesting and useful. We had a number of questions that were submitted, and many of which you have already touched on in the talk, but it'd be great to pick up on some of those things with you. You talked a bit at the beginning about causes of social anxiety. One of the things that was asked was about social media and whether you feel that social media has a part to play in social anxiety and potential increases in social anxiety.
Well, yes, this is a very interesting topic. Quite a number of people with social anxiety actually look to social media as a possible way of, starting interactions with people and making friendships. So you might see it as potentially having some advantages. You don't have to meet someone in person straight away. But we have done some research on this, and we find that in social media, such as Facebook and things like that, the sort of problematic behaviors that occur in normal face-to-face communications also occur on social media. So people with social anxiety tend not to post very much, but they spend an awful lot of time looking at other people's postings and comparing themselves with those, and thinking that these other postings are very realistic rather than self-aggrandizement, which they often are, of course. So it makes them often feel worse. They also tend to use their safety behaviors in their posts, and there's a tendency for them to put themselves down in the posts, almost to get in a preemptive criticism. So they often don't find social media a positive place to be, but also feel drawn to it often because of this idea that it's important to be in those networks. So yes, it can be quite problematic. And of course, we all know that there's a fair amount of bullying and abuse that's going on in social media. And for people with social anxiety, this is something that they are particularly susceptible to.
So do you find yourself using social media within therapy, or because of the uncertainty about the sort of response people will get, do you tend to steer clear?
So in therapy, we often look at whether people are using social media, and we look at how they're using it. And that is part of what you pay attention to in the therapy, as well as normal face-to-face interactions. So it's not a matter of saying don't use it, but to try and look at how people are using it, ways in which it might be unhelpful for them, and help them to experiment with using it differently.
Yeah, great. Thank you. And I think there were a few questions about the possible role of social media in bringing about possible changes in social anxiety in recent years. And there have also, of course, been questions about the pandemic and whether that has had an impact on social anxiety. Is that something that you've seen?
Well, yes. So, I mean, I think, people sometimes wonder, is social media making, social anxiety and other anxieties more common? I mean, if you look at the epidemiological work, there has been an increase in the rate of anxiety disorders in the last 15 years or so, but it's rather specific to a young age group. In fact, the age group that you specialize in, Cathy. So particularly up to age 24 is the one where we get the bigger increase. We're not really showing an increase in the older groups. Some people say, of course, that the younger groups are particularly into social media, and so that might be part of the reason for the increase. But there are many other pressures in society on young people, so I think it's very difficult to disentangle that. In terms of the pandemic, there's positives and negatives. So as you know, I'm the sort of clinical advisor for the government's Improving Access to Psychological Therapies, or IAP program, which aims to deliver the sorts of treatment I've been talking about in your local services. And it treats about 640,000 people every year with cognitive behavior therapy and some other evidence-based treatments. And of course, that was mainly face-to-face. But when we went into lockdown on the 23rd of March last year, seems a long time ago, isn't it? That was no longer possible. But NHS England made a decision to keep the services open. And so really in a period of about 2 weeks, all the therapists converted to delivering therapy remotely from their own homes into other people's homes, particularly through this media that we're using now, Teams, but also on phone calls. And our team sort of dropped what it was doing for about 2 months and focused on writing articles to help the therapists learn how to deliver treatment effectively remotely, and also did a lot of webinars showing people how to do that, and video clips. And if people are interested in that, they can look at some of the material on our free resources website called oxcadatresources.com. And there's a COVID-19 page there, and you can see a lot of that work. Interestingly, because we were moving into uncharted territory and no one really knew, was this going to work or not? But the data from the IAP program, because we do collect outcome data on everyone who has a course of treatment, and it's published by the government, by NHS Digital, is that the outcomes were maintained throughout the pandemic. So although we moved to almost complete remote delivery, the services continue to get as good outcomes as previously. That doesn't mean, however, that all therapy should go remote. And as we're starting to come out of the lockdown, clinics are opening again. And it is very important that patients are given a choice between whether they have therapy face-to-face or remotely. Because there are some people who the remote just isn't suitable for. There are many people who have living circumstances, which mean there isn't a private place in their home that they can link up for a remote session. For other people, they really do value being in a room with someone else. And it is very important that our mental health services are commissioned in a way which makes them available on an equitable basis to everyone. So NHS England will be publishing waiting times for local waiting times for face-to-face therapy as well as remote therapy, just to ensure that commissioners make sure that patients have fair choices and can go either way. So that's a positive thing. There is, of course, a negative thing, which is for some people who have social anxiety, the pandemic and the lockdown and being able to work remotely seemed a bit of a blessing to start off with. But it means they've gone for a long period without much face-to-face contact and are quite worried, I think, in some cases about coming back to the office. And so I think people will go through a phase of adjustment. I think it's very important for people to remember what they were doing and how they were managing in the office before the pandemic, and really to realize that gradually going back to exactly that mode of operation will work just the same way as it did before. And there isn't anything to fear, but I think not to be hard on yourself and to realize that there could be a tricky transition and you may well feel anxious for a while, but I think persist through that without criticizing yourself.
And I know that these sessions, we're often joined by a lot of people who are in line management positions or who might be supporting students. So just thinking about that point about people who may be struggling with social anxiety as they return to more in-person interactions. Is there anything that you think you'd like to share with people who are in that position of supporting others in the workplace or in university settings?
Yeah, so obviously there's a mixture of concerns that people will have. Some of them are, social interaction concerns, but some of them are also personal safety to do with COVID. And a key principle in anxiety is for people to feel in control of whatever is happening. So it is really very important if someone's concerned to have individual meetings with them to discuss, ways in which the work environment can be structured where they feel that they're in control of what's happening, and they can gradually sort of expand their range as they go through things. It's really very important not to just impose rather rigid rules about return to work for everyone. And this is a principle that the university is adopting at the moment.
Thank you. And related to that, we had some questions about supporting others more broadly, potentially friends or family members. And so one of the questions was really about how to find the right balance between accepting someone's social anxiety versus sort of having, using the right tools to be able to help them move beyond that. So are there any particular thoughts you'd like to share with friends or family members who might be concerned about somebody that they care about who's struggling with social anxiety? And just related to that, there was also a question about where you might feel that somebody is smoking or drinking alcohol or taking drugs excessively in order to try to manage their social anxiety, and again about how to manage that sort of situation.
Yes, well, I think it goes back again to the idea of people with social anxiety feeling in control. So I think what you don't want to do as a loved one is to decide that you are going to sort of do a bit of undercover therapy and you're going to push someone forward to do all the things that you see in the videos that happen in professional therapy, because then I think someone is likely to feel not particularly supported and feel they're being coerced into things. So whatever you do, you must do with the agreement of your loved one as you move together. But obviously there are many things that people can do. People can, if someone's concerned that they've come across badly, they can give feedback about how it's actually looked different to the outsider than it felt. Often, if you're going with someone who has social anxiety, then to an event or something, make a point of introducing them and bringing them into the conversation, and then you can fade a little bit as they seem to be more comfortable and they're having a success experience. But it's really gradual support rather than pushing people too hard.
Thank you. And we had a few questions that were really about managing social anxiety in objectively difficult social situations. You talked about the social anxiety disorder diagnosis would typically would come when you have things that are a bit beyond the objective threat reality. But we had some questions, for example, about dealing with social anxiety associated with socializing in new or different situations. So for example, as an international student. So I wondered if you had any comments about the extent to which the same sort of processes and strategies might apply in those sorts of situations.
Yeah, so it's often the case that if someone is prone to social anxiety, novel situations seem potentially more threatening. But I think the key thing to realize is that you as a person haven't changed, and you're very likely to be just as acceptable to new people as you are for the people that you already know. But it's a matter of trying it out. So try not to hold back, try and be yourself as much as possible. The key problem is these sort of safety behaviors where one's censoring what one's saying, one's watching oneself all the time, one's making your own judgments in advance of anyone else. And so try not to do those. And I think if you're an international student and you're here and it's a different environment, then actually people often are really interested to hear about other people's experiences, and they often give quite a lot of latitude to people coming from another culture. So one suspects that should be your experience, and it's generally a feature of the English that they do their very best to be interested in other people. If they're not, then that's not a good feature of them. It's not a negative reflection on you.
Thank you. And we had a question come in this morning about the interrelationship between autism and social anxiety, and a question about the sorts of approach that you take in cognitive therapy and how that works, or whether that works with autistic people as well.
Yeah. So there aren't any, as far as I'm aware, randomized control trials that are specifically focused on people with autism spectrum disorder and social anxiety, although you may know some that I don't know. But with this particular treatment that we've been talking about, we have a subgroup of people with autism spectrum disorder who've done quite well. But there are some additions to the treatment. You spend a bit more time helping people understand what other people might be thinking in a particular situation, because that's obviously something which is a bit more tricky for many people with autism spectrum disorder.
Thank you. And just one last question.
Also a question about olfactory reference disorder.
That's right. I was going to ask, so there was a question about, you know, the validity of different subtypes of anxiety, and somebody specifically referred to olfactory reference disorder. Yes. And what the implications for treatment might be in these situations. Yeah, okay. So, I mean, in general, you know, the anxiety disorders are divided up into lots of subtypes, like panic disorder, social anxiety, obsessive compulsive disorder. And I think historically that's been quite useful, because we've found that the treatments need to be rather tailored to those conditions in order to get the best results. But the interesting thing is that that tailoring has identified some maintaining factors that are particularly prominent in those conditions. And you get a lot of mileage by changing them. But we've often found that when we look at other conditions, they're also there, but in a milder form. So there's now a movement to create what we call transdiagnostic treatment, where you use the learning that's come from these specific disorder treatments to have a series of interventions for all of the sort of maintaining processes across different conditions. But olfactory reference disorder is a very interesting condition. So for those people who don't know about it, it's a condition where people have a false belief that some part of their body smells terrible. And often, of course, it means that they avoid social interactions because they're worried that other people will notice the smell. It is a false belief. They don't smell that way, but they really can believe it and are concerned about it. And it does produce a lot of distress and a lot of avoidance behavior. It is possible to treat, though, with some of the key ideas that we've discussed today, but tailored to the condition. So the first thing when you're dealing with any sort of emotional and upsetting belief, which may, you know, be false, but the person thinks it's true, is not to just say you're wrong and not to argue with people, but rather to open things up as a sort of exploration. And so the first thing you'd start with there is to say, well, you know, I know that you feel that you smell very badly, and you probably can smell that. But it is possible that that's still mistaken, because the way our beliefs can change our perceptions. And you might start with some illustration from psychology about that happens. Like, for example, the sort of two faces looking at each other versus a lampshade, sort of illusion. And if you tell people it's one thing, that's what they see rather than the other. And once people have got the idea that it's quite normal for our beliefs to affect our perceptions, including probably our sense of smell, you can then get people to test out whether the smell is as strong as they think by, for example, sitting much closer to people than they normally would and looking for adverse reactions, not using so much cologne and perfume and things to hide things, and then having more interactions with people. And those sort of behavioral experiments seem to work very well, but only if you first help people see that it is really possible for beliefs to affect perception. So it's not like they're crazy. This is a normal psychological process that is going on, driven by their belief, but producing what to them is very real perceptions. I just want to ask one very quick question to finish, and because there were a couple of questions about maintaining positive change in the long term, where people reflected that overcoming social anxiety sounds like a singular event, but sometimes it feels like a continuous effort. And I wondered if you could comment on the long-term impacts of your interventions.
Yes, so that's really one of the most interesting things, I think. So if you look at psychological treatments, say for depression, which naturally is a recurring disorder, you find that they reduce the risk of recurrence, but they don't abolish it. And so you still get some people having relapses following courses of psychological treatment, say cognitive behavior therapy for depression. The long-term follow-ups of people who've gone through this sort of course of treatment for social anxiety disorder look different. Pretty universally, people maintain their gains when assessed 5 or 10 years later compared to at the end of treatment. And in some of the trials, they're actually doing better 10 years later. So what's going on here? Well, I think, you know, the treatment isn't short, it's 3 months or so, quite intensive work. But during that period, you really get to understand that you come across much better than you think. And that encourages you to have more social interactions. And it has a knock-on effect. You're going to meet more people, you'll develop some new best friends, and they give you further confidence for the future. So it's very important in that way. But this is something that really comes from going through one of these sort of full courses of treatment.
Thanks very much, David, and great to hear those positive outcomes to finish on. And thank you ever so much for giving us your time and joining us today. And thank you to everybody who's joined us. Before we finish, just to remind you, please do take a bit of time now, particularly if anything that we've spoken about today has been thought-provoking for you. Give yourself a bit of time before you rush on to the next thing. But please do also give us some feedback to help us plan future talks. And you'll see a link to a very short survey in the chat box. And just also a reminder that the next session is on the 18th of November with Dr. Kirsten Smith, who'll be talking about coping with grief after bereavement. And as I mentioned before, there's also now a really wide range of videos to watch on our YouTube channel as part of this series. So please do go back and have a look at that too. But I'll just finish up by saying thanks again, David. It's been a really fantastic talk. I'm sure people will have found it extremely useful. And thanks again, everyone, for joining us. Goodbye.
Bye.